This video is going to demonstrate all of the special tests for the shoulder evaluation for this week's lab. So first I'm going to start off with the Apley Scratch test. So remember, there are 3 different components to Apley Scratch. First I'm going to instruct the patient to bring his right arm across his chest to his left shoulder. Good. Next I'm going to have him turn around, and I want you to reach behind your back and touch as high as you can on your spine. Good. So I would mark about here, and then I would say, okay, can you do it on the other side? And then I would obviously compare bilaterally. Same thing with reaching across the body. And then lastly, I would have him reach up and around. So go from the top of your neck, reaching back. Good. And then noting what level he's able to reach on his right side as compared to his left side. Go ahead and relax. You can turn around. Next we have the drop arm test. So I'm going to ask the patient to raise both of his arms all the way out to the side, all the way up. Great. And then slowly all the way down. So a positive sign would be if he was unable to control the movement on the way down. So if one arm tended to drop as he was trying to control that, that would be a positive sign for potentially some type of rotator cuff muscle injury, specifically the supraspinatus muscle, because that facilitates shoulder abduction. Next we can do the empty can test. So I'm going to bring him into scaption. So that's about, if you go from 90 degrees of flexion, slightly out into like 45 degrees of shoulder abduction, he'd be right about here. I'm going to have him, he's basically making a can or holding a can with his hand. He's going to empty the can here, and I want you to hold this position here. I'm going to try to push down, don't let me, okay? Good. Holding for about 5 seconds or so. If he had any pain with that, you could bring his thumb up towards the sky, hold here. This should alleviate some of his symptoms. If he was unable to hold that, or if he had any pain, that may be indicative of potentially a rotator cuff impingement, biceps tendon impingement, or any type of just general rotator cuff damage, specifically with the supraspinatus. Next we have the Gerber liftoff, so I want you to turn around. This is assessing again for the rotator cuff, specifically the subscapularis. So he's going to, again, just reach behind his back. Good. And I want you about level with the iliac crest. I'm going to stabilize the shoulder, and I'm going to ask him to just lift his hand off of his back. Good. If he was not able to do that, then that would be a positive sign for potentially subscapularis injury. If he is able to do that, I'm going to place my hand on top of his, and I'm going to apply some resistance. So go ahead and lift off again. Good. And relax. So again, if he wasn't able to do that, then that would be a positive sign for potentially subscapularis injury. Next are the special tests specifically for joint laxity, specifically somebody who may have suffered from shoulder subluxations or dislocations. So I'm going to have you lay on your back. The first one I'm going to do is apprehension and relocation. So I'm bringing him up into 90 degrees of shoulder abduction and 90 degrees of elbow flexion. I'm just going to use my hip to keep his elbow in line with the glenoid fossa. I'm going to bring him into shoulder external rotation while applying slight, stabilizing the humeral head. And I'm watching his face to see if he is showing any emotion of apprehension, because oftentimes when people are dislocating their shoulders, it's when they're in this provocative external rotation movement. So if I'm in maximal external rotation and I take my hand off that was stabilizing the humeral head, and he shows a look of surprise or apprehension, then that would be a positive sign. Next we have the glenohumeral glide, so I'm going to have you scoot off the table. Good. So I'm just going to stabilize his arm using my right arm, and then my left arm is just going to apply a anterior-posterior glide on the humeral head. I could also pull in inferior and superior to see if there's any excessive movement within that joint space here. This is why it's really important for you to compare bilaterally, just to make sure that he doesn't have excessive movement on one side compared to another. From here, I can do the jerk test. So I'm going to bring him into 90 degrees of shoulder flexion and about 90 degrees of shoulder abduction. I'm going to put my hand on his scapula, so on the posterior side of the scapula. I'm providing an axial load down through the humeral shaft. While I'm doing this, completely passive, I'm bringing him across into horizontal adduction and noting any clicking or popping sensation on my hand that is stabilizing the scapula in the back. From here, I can do posterior apprehension. So I'm just going to keep my arm in this position here, and then again, just applying that downward axial load through the humeral shaft. If he is somebody that has had a posterior dislocation prior, then he may, again, similar to the apprehension test, show some type of sign of apprehension or muscle guarding as I'm doing that test. And then lastly, we have the sulcus sign, so I'm going to have you sit up. So for the sulcus sign, I find it easiest if I roll the patient's sleeve up. He's going to completely relax his arm to his side, and all I'm doing is just applying a downward force or an inferior force on the humeral shaft. And I'm just looking to see if there's any type of step-off deformity or excessive movement of the humeral head as I'm pulling inferior. So this may indicate some potential excessive laxity within that joint space. So again, you would just notice some type of step-off deformity. You can give a couple of tugs, it's certainly fine. Next, for the special test for rotator cuff and or biceps tendon impingement, there is the Neer and the Kennedy-Hawkins tests. So both of those tests are done completely passive. For a Neer, think Neer by the ear. So I'm going to take Cole's arm. He's going to be completely extended. I'm going to maximally internally rotate his arm, stabilizing the humerus, and I'm just passively bringing him up all the way into shoulder flexion. If he feels any pain, tightness, or clicking, and he reports that to me, then that would be a positive sign. For Kennedy-Hawkins, I'm going to bring him up to about 90 degrees of abduction, 90 degrees of flexion. I'm going to internally rotate his arm while bringing it across his body. Okay. Same thing as the Neer's test, it's done completely passive. If he notes any pain, tightness, or clicking, then that would be a positive sign for potentially rotator cuff or biceps tendon impingement. For Jurgensen's, Speed's, and Ludington's, those are specifically looking at biceps tendon impingement. Speed's test is done with the patient completely supine with their hand palm up towards the sky. I'm going to stabilize the humerus, and I'm going to ask Cole to just bring his palm all the way up towards the sky. So go ahead and pull up. Good, as far as you can go. And relax. So if he reported any type of stinging pain or localized pain within the biceps tendon region in between the greater and lesser tuberosities, then that would be a positive sign for potentially biceps tendonitis or tenosynovitis. For Jurgensen's, he's going to be completely pronated. So if his palm is up, that's supinated, palm down is pronated. I'm going to palpate the biceps tendon. And I want him to bring his hand from full pronation to full supination. So this is the movement that he's going to be doing. I'm going to shake his hand. He's going to keep his elbow towards his side. Bring your elbow in. There you go, good. And I want you to go like this movement, okay? And I'm just going to resist this movement here, so go ahead. Good. If he reported any tenderness or if I noted any crepitus within that biceps tendon, then that would be a positive sign for potentially biceps tendonitis. Lastly, for Ludington's, Cole is going to put both of his hands behind his head. Same thing as the sulcus sign, I may just roll the sleeves down for my patients, and I want Cole to make a bicep on both sides. Good, and then this side here, great. So I can see that both of those muscles are intact. If for some reason he wasn't able to make a muscle, then that may indicate potential biceps tendon rupture. You can relax. Okay, next we have some of the special tests for potential AC joint pathology or labral injury. The first is going to be O'Brien's test. So I want Cole in full internal rotation, elbow extended, and reach all the way across his body. So thumb down. I'm going to stabilize the humerus and apply a downward pressure. If you reported any pain deep within the glenoid fossa or in the labrum that may be indicative of potential impingement or labral injury, I could bring him into slight external rotation and more into shoulder flexion. Hold here. This may alleviate some of his symptoms. So for the O'Brien's test, maximal internal rotation, downward force with shoulder adduction. For the AC traction test, so it's going to be very similar to the sulcus sign, except instead of looking for the depression from the humeral head from the glenoid fossa, you're actually looking to see if there is any distraction from the AC joint itself. So again, just applying that downward force, and then just noting where the deformity is. Is it in the humeral head or is it in the AC joint itself? You could also do AC joint compression. So I'm basically just providing a compressive force between the clavicle and the scapula. If there was any excessive movement as I'm compressing that, or if you had any localized pain on the AC joint itself, then that would be a positive sign. Next, we have the piano key sign. So just like how you press a piano key with 1 or 2 fingers, you're going to push on the clavicle, primarily the most lateral third of the clavicle, and you would note if there was excessive movement, almost like you're playing a piano key, if there was damage to the AC ligament right out in here.